The two big studies that have been performed that have justified the use of daratumumab in a non-transplant eligible patient are called ALCYONE and they're called MAIA. The first trial was conducted predominantly in Europe, and it worked on the basis that bortezomib, melphalan, and prednisone was an accepted regimen in European circles for treatment of elderly myeloma, and to which the trial then looked at VMP versus VMP and daratumumab in a randomized phase 3 fashion for patients who did not plan to go to autologous transplant. There were quite dramatic differences in progression-free survival, overall response rate, and depth of response in favor of adding daratumumab to the VMP cocktail. This has resulted in approval of that regimen, VMP-DARA, again bortezomib, melphalan, prednisone, and daratumumab, by the FDA and by the European agencies. However, the use of melphalan in the United States fell out of fashion many years ago, and for that reason it is not a regimen that has been particularly embraced in the United States, although it is, of course, quite feasible to give and does offer the opportunity to offer daratumumab to your patients. The second large phase 3 trial, perhaps the one that is more impactful in the United States, is the MAIA study. The MAIA study built on the highly effective use of lenalidomide or Revlimid and dexamethasone in elderly patients. With the original studies of RD showing superiority over melphalan, prednisone, thalidomide, and melphalan, prednisone, lenalidomide, with an overall progression-free survival of around 26 months for the RD combination. The MAIA study took patients not destined to go to transplant. Over half of them were over age 75 years of age, and used lenalidomide dexamethasone at fairly standard dosing, 25 milligrams of lenalidomide daily for 21 out of 28 days, dexamethasone at 40 milligrams once weekly as a control arm, which did very well with about 30 months or 31 months of progression-free survival, versus the same two drugs to which we added daratumumab. Daratumumab is given at 16 milligrams per kilogram once weekly for 8 weeks, once every 2 weeks for the next 16 weeks, and then once a month thereafter. This was again a very positive study in favor of the use of daratumumab in this cocktail of DRD, daratumumab, Revlimid, dexamethasone. The overall response rate was about 93%. There was a dramatic improvement in progression-free survival, almost a halving of the risk of progression, at least until the time of the study was reported, and more than a doubling or tripling of the depth of response in terms of minimal residual disease negativity. This was a very positive study. It has also resulted in FDA approval of this regimen and is now perhaps a new standard of care in this patient population.